Hello, and welcome to the CAP Today webinar for Wednesday, June 11th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host, and then I'll moderate a question and answer session after our formal presentation. Today's webinar is entitled Screening Smarter, CFTR2 and Variant Interpretation. This is a very important program. For those of you who may not be on the inside, this is all about the CF gene, cystic fibrosis, well known for many years and well characterized as a gene. We have a fascinating talk for you. And this webinar, I want to say, is made possible by a special educational grant from Devicer. You see that right there. This is the second time we've worked with them this year, and I do want to acknowledge Devicer for this generous support. And I want to thank them for their help in bringing us this very important event. Today's speaker is Karen Raraigh. She's a Master of Genetic Counseling and a certified genetic counselor. She's an assistant professor of genetic medicine at Johns Hopkins University, which needs no introduction, and she trained at the University of Maryland. So she's we know her very well in Maryland. Before I ask Dr. Karen Raraigh to begin, though, I want to share a few tips that I hope will enhance your enjoyment of today. You have a pod on your screen, and on that pod you can type in requests for any technical help. We have live personnel standing by to help you with audio, help you with this website if you need it. And also, though, the real use for that pod is to put in your comments and your questions. We have real experts here today, so share your comments and questions, and we'll do our best to get to all of them. I want you to know we'll post the audio and slides of today's presentation in about 10 days, and the source and location of that will be captodayonline.com. That's our major website for CAP Today. You should expect to see some email follow-up, both from ourselves and Devicer, so I want to alert you to that. And finally, it's important that I add that CAP Today does not embrace or endorse any products or services that are mentioned necessarily in today's webinar. Any remarks of mine are purely personal, not to be taken as policy of CAP Today or the College of American Pathologists. And now with that introduction out of the way, I'm going to ask Karen Raraigh to begin her very fascinating presentation. Karen Raraigh.
Thank you so much, Bob, for the introduction and for the invitation to speak today. I am delighted to talk to you about CFTR2 and its impact on newborn screening and CF carrier screening through variant interpretation. These are my disclosures for today's talk. Here are today's learning objectives, and I'm not going to read them all. You can read while I chat in the background here. I should note that to address these, I will be talking about relatively recent updates to recommendations for CF carrier and newborn screening. And while these guidelines are US-based, the guidelines I'm going to be talking about, their framework can certainly be applied elsewhere. We're going to start with an overview of CFTR2, and that stands for the clinical and functional translation of CFTR. So it's CFTR twice. Probably we should have called it CFTR squared, but we landed on CFTR2. And this is an international initiative with the goals to analyze CFTR variants that have been reported in individuals with cystic fibrosis, or CF, from around the world. And then we assign disease liability to each variant. So that's determining whether the variant causes CF or not. And then make that information about each variant available essentially to anybody who wants it: researchers, clinicians, patients, families, other care providers. So how do we do this? Here's a quick look at our process. First, we populate the CFTR2 dataset. So we collect patient information from CF registries, so patient registries, usually nationally based. And that information includes genotypes, so different CFTR variants, and then the associated clinical data from individuals with CF who are part of those patient registries. Then we list the CFTR variants reported in our collection of patients in order of frequency to prioritize interpretation from most frequent to least frequent. Analysis of each variant happens next. Each variant undergoes clinical analysis, functional analysis, and a population or penetrance evaluation. I'll discuss those in detail in further slides. And then interpreted variants get placed into one of these three categories. And as of our latest update in September of 2024, we've interpreted over 1,000 variants as CF causing, 55 as variants that lead to varying clinical consequences, and 27 as non-CF causing variants. So here's some more details about those interpretations. Because CF is a recessive condition, we're operating under the assumption that two variants are necessary for disease. So a CF causing variant is expected to result in cystic fibrosis when found in trans with another CF causing variant. And of course, we know that severity of disease can be variable for these individuals. A non-CF causing variant, also fairly straightforward, is not expected to result in CF when found in trans with a CF causing variant. And variants of varying clinical consequences, or VVCCs, result in CF in some people, but not in others, when they're found in trans with a CF causing variant. And the not others in this category may be totally asymptomatic or have other milder diagnoses or designations like CFTR related disorder or CRMS and CF SPID. So we provide these interpretations and a whole host of other data. So clinical information, the results of functional testing, and other kind of special notes on the CFTR2 website, which you can find at cftr2.org. Now, here's a timeline of CFTR2 over the past decade plus. So in 2012, we released online our first iteration of CFTR2, which had nearly 40,000 individuals with CF or from CF registries in 25 countries. And with that initial data set, we were able to assign disease liability or interpret over 200 CFTR variants. Now, of course, the data that we get from registries takes a little bit of time to process. And so that data set had clinical data through about 2008 or so. In 2015, we released the second iteration of CFTR2, which had over 89,000 individuals from 43 countries and regions. And with that data set over multiple iterations, we were able to interpret a total of 804 CFTR variants. And then just at the end of 2024, I was delighted to announce our most recent release of the current iteration of CFTR2, which has nearly 123,000 individuals. They come and represent 55 countries, regions, territories. And with that data set, we have thus far been able to interpret 1,167 CFTR variants, and those are all available for search on the CFTR2 website. I want to recognize the tremendous contribution from CF registries around the world, without which this data set quite literally would not exist. So this is a map shaded by the size of the data set from each contributor. It covers 55 countries, territories, and regions. And here are the names and the number of patients included from each contribution. So you can see we have fairly good global representation. I'll talk about the wholes in a minute. Excuse me. You'll notice that Europe is colored almost uniformly. That is not because the countries in Europe contributed all the same number of patients, but it's because we get one data contribution from the European Cystic Fibrosis Society patient registry. And that includes data, for us anyway, from 37 countries. I'll also specifically mention that countries like Israel and Turkey, which may not be geographically European, participate in the ECFS patient registry and are included here. Though we are proud of the worldwide coverage of CFTR2, we know that we're missing data contributions from several areas of the world. And we are really glad to say that we have contacts in the countries shown here, some of whom are actively working on a contribution to add to our data set. And so we do expect more growth of CFTR2 in the future as some of those contributions roll in. Now, if we go back to this schematic here, I'd like to talk a little bit more about CFTR2 methodology, which I mentioned earlier. We have used the same concepts for evaluation since the inception of CFTR2, and that's to look at 3 categories of data. So here they are. We're going to talk about clinical data first. Here, we look for evidence that the variant occurs in someone or in several someones in our data set who appear to have cystic fibrosis. So ideally, we look for people whose genotype includes our variant under evaluation, and the example here is Q237E. And the other allele in the genotype should be severe or CF causing or a null variant. That way, essentially, no function is coming from that null allele. So we can really just assess the effects of the variant that we're interested in looking at. So we look at this group of people and we evaluate the mean sweat chloride or the prevalence of pancreatic insufficiency. Those are both 2 sort of markers for cystic fibrosis. And again, we're just looking for clinical evidence that people with this specific variant or genotype have CF. Each variant also undergoes a functional assessment, which sounds really simple. You've got a genetic variant, figure out what it does. But in order to do this, fortunately or unfortunately, we have to consider a lot of possibilities. So I'm not going to talk you through all of this because it's too complicated to address quickly, but suffice it to say, we have to consider lots of ways that the CFTR protein could potentially be disrupted by a genetic variant. Some of these are potential effects on the RNA, while some are effects on the protein itself. And there are several different types of functional tests that we can do and perform depending on the type of variant and what we think the impact may be. This results in really high quality data that aids in our study of each variant. We have worked with many, many collaborators over the years to complete these functional studies, which, as I'm sure you can imagine, are typically quite time consuming and can be very labor intensive. Lastly, we consider whether each CFTR variant has any evidence of non-penetrance. That is an example in a person in whom the variant appears not to cause disease. We also assess the frequency of the variant in the general population using data sets like NOMAD to gain further insights on pathogenicity, as variants that are more common in the CF population tend to be pathogenic, and variants that are more common in the general population tend to lead more toward benign. Now, this multifaceted approach to variant interpretation has really served us quite well over the years. We've only reclassified 12 variants since CFTR2 launched in 2012. 6 variants of varying clinical consequences were reclassified as non-CF causing. 2 were reclassified as CF causing. And 2 went to the category of unknown significance, which is a category we previously had but no longer use, at least temporarily. We may have to bring it back. The 2 variants that went to unknown significance then further were reclassified, 1 to CF causing and 1 to non-CF causing. We had 1 variant that started as CF causing, went to variant of unknown significance, and then went back to CF causing. Notably, we also had a handful of variants that started out as variants of unknown significance and were reclassified. I'm not including those here because we should be trying to reclassify variants of unknown significance. That should be a major goal. And we really believe that our use of high quality data and our multiple ways of assessing each variant has led to our robust interpretations that have held up well over the years. So to sum up CFTR2, this is a project that uses high quality clinical data, functional studies, and frequency and penetrance information to provide expert CFTR variant interpretations to the CF community. This type of information is frequently used to aid in clinical decision-making related to diagnostics, prognosis, and treatment. And as we'll get into next, CFTR2 is already and will continue to impact policy decisions. Now, how does it do that? You probably know that traditionally, screening was done by testing for a limited number of CFTR variants that we know definitely cause disease. In both the CF newborn screening and carrier screening realms, labs now are increasingly using DNA sequencing technology rather than relying on limited variant panels. Now, of course, the issue with this is that we're pretty good at finding genetic variants by sequencing, but not always so great at interpreting what they mean. And in a screening scenario, you really want to know the meaning of what you're finding because we only want to be reporting actionable variants that could actually cause disease. Luckily, CFTR is one of the most sequenced genes, and we actually know a fair bit about the variation within it. So what can CFTR2 provide for people who are making decisions related to screening protocols? Well, we can provide variants that represent a global population. We can provide information about whether a variant causes CF or not. And we can provide information about the frequency of those variants in the CF population. So essentially, CFTR2 can provide information that informs people designing screening protocols about which variants should be included in or reported as part of screening. We're going to talk about CF carrier screening first. I have a timeline here that's going to show you the progression of CF carrier screening milestones on the top in orange and progression of understanding of CFTR variant interpretation on the bottom in blue. Now, I'm not going to go through all of these milestones in detail, but please note that the first CF carrier screening recommendation came in the late 1990s. And then in 2004, the famous ACMG 23 list of variants to be included in CF carrier screening was published. After being revised down from a list of 25, that's a longer story we're not going to get into. This ACMG 23 list was essentially the minimum list of CFTR variants that should be looked for or included in a CF carrier screen. Notably then, it wasn't until 2023 that that ACMG list of 23 was updated to 100. And this came shortly after CFTR2 had released an increased list of variant interpretations up to 485 variants. So why did we change from that original list of 23 to 100? Well, the bottom line here is that screening for the 23 variants recommended in 2004 was working really well, but only if a person was either white European or Ashkenazi Jewish. And so actually, it wasn't working all that well because it was not an equitable test. And you can see here that the detection rate was much lower for people who were Asian or African compared to Ashkenazi Jewish individuals or non-Hispanic whites. And so in 2020, the American College of Medical Genetics and Genomics, or ACMG, convened a committee that asked us to increase the number of variants recommended for carrier screening such that the detection of carriers was more equitable amongst ancestral groups and sensitivity was increased overall. And I was part of that committee, so I'm going to take you through how we approached this. We chose to start by identifying variants at the disease level. So that is from a disease population, a cystic fibrosis population, determine all the variants that we might want to consider including in a carrier screen. And from there, we end at the population level. So that is determining how many variants will achieve our set frequency metrics. And then when taken as a group, we'll reach an acceptable level of carrier detection in all groups. So you may remember from the previous slide, carrier detection in some groups was high and very low in others. The goal here is to get that detection rate up in all the ancestral groups. I've already given you a preview of how we are working through this process for CF, but here's an even longer, though not all-inclusive, list of considerations when we think about data sets in general. So things like the database or databases to source the variants, how large we want the list to be, how confident we are in the pathogenicity of variants in a particular data set, variant frequency, cost and ease of test design, and more. Taking just that first consideration, what database to source the variants from, that had its own set of challenges, like population makeup, potential overlap amongst databases. So if we said, oh, we have to consider variants reported in multiple databases, well, if one feeds the other, then it's just a duplication, not multiple reports. And then inclusion bias. We also had challenges like what to do if there are conflicting data or interpretations within a data set, how the definition of disease is formed within the data set, the severity spectrum, and what to do about rare variants that may be absent from population data sets. So they're in the disease data set, but they're not in the population. What do we do about those? So we considered and discussed many things, including which disease databases to use, like CFTR France, ClinVar, CFTR2, and then population databases like All of Us, the UK Biobank, and Nomad. And so then we sort of took all these challenges and we considered things. And after putting together all the nuances and pros and cons of each data set, we ended up landing on CFTR2 to source the list of pathogenic variants to consider for carrier screening, and Nomad to aid us in whittling down that list by frequency. Now, I'm going to walk you through a figure that I modified from the paper that resulted from this committee with our updated recommendation. We used the previous ACMG list of 23 and the list available from CFTR2 at that time to determine an initial list of CF-causing variants. And that initial list had 416 CF-causing variants that we would consider including in a carrier screen. So then we reviewed the list, and there were a couple reasons you could automatically exclude something. Some variants underwent a manual review, and then those were removed, and we took the revised list, which got us down to about 197 variants, and we looked at NOMAD to perform our frequency and sensitivity evaluation. And I'm going to walk you through that in the next slide. But what we landed on was this very nice round number of 100 variants. We weren't necessarily aiming for that nice round number, but it just worked out. And what we ended up doing was looking for a list of variants that would achieve 95% sensitivity or coverage overall and within specific ethnic populations. So this is just a closer look at how we did that frequency evaluation using NOMAD. Essentially, we looked at the major US ancestral groups and figured out how many variants would have to be included from each population to achieve 95% sensitivity in that population. You can see that for the African group, that 95% sensitivity in sort of the second to lightest blue color is 39 variants. You only need to look at 39 variants in the African group to get 95% sensitivity, and actually only 4 variants in the Ashkenazi Jewish group. So then we merged these lists into one longer list and looked at how many variants would hit at least 95% sensitivity in each group listed here. And the answer ended up being exactly 100. So in some populations, that list of 100 actually far exceeds 95% sensitivity. And you can also see in this figure how many variants would have to be looked at to achieve only 80% sensitivity, 90%, or 99% sensitivity. So in summary, the use of CFTR2 to define pathogenic variants for CF carrier screening aided in the development of a guideline recommending a minimum list of 100 CFTR variants for inclusion, up significantly from the previous 23. This updated list of 100 is expected to result in a much more sensitive carrier screen for many groups within the US and improve equity in the screen. Because we now have defined the framework for how to do this, this list can also be refined as CFTR2 and NOMAD or other data sets that might be used increase in size and complexity. Switching gears, now we're going to talk about CF newborn screening, and you'll see some parallels here and how CFTR2 has impacted those recent recommendations. So similar to our carrier screening timeline, here's a chronology of newborn screening milestones compared with CFTR variant interpretation milestones. So notably, Colorado actually started newborn screening for cystic fibrosis in 1982, a full 7 years before the CFTR gene had even been discovered. But it wasn't until about 2010 that all US states had cystic fibrosis on their newborn screen, because each state gets to handle newborn screening as they like. And so these protocols, including which diseases are actually tested for, really vary state to state. Interestingly, after newborn screening programs started incorporating a DNA testing component, many ended up using the ACMG 23 list that had originally been developed for carrier screening. CFTR sequencing as part of newborn screen came around in the early aughts for California and in the 2010s for 2 other states. And then it wasn't until earlier this year, in 2025, that the CF Foundation released its first newborn screening guideline. For those not familiar, I'm just going to walk you through the very basic algorithm of how cystic fibrosis newborn screening works in the US. There are 2 main protocols that are used. One is called IRT-DNA, and the other is called IRT-DNA-seq, short for sequencing. So all states start by measuring immunoreactive trypsinogen, or IRT, from the dried blood spots that are collected as part of newborn screening. IRT is a pancreatic enzyme precursor that is elevated typically in babies with CF. It's also elevated in many babies without CF, including CF carriers, and then babies that may just have another reason for IRT elevation, like a traumatic birth or prematurity. Newborn screening specimens that are found to have an elevated IRT, and sometimes that's done twice, depending on the state, those are sent to Tier 2 testing, which uses a DNA component. This is all still part of what the state health department does for CF newborn screening. Now, most states in the US are still using just the IRT DNA protocol and perform only DNA variant panel testing. The panels range in size from a very small number of variants to several hundred. And actually, since this figure was published, the upper limit of the panels has increased to a couple more hundred variants than just 300. In states using the IRT DNA-seq protocol, specimens with only one CFTR variant found on the panel will progress to CFTR gene sequencing in an attempt to identify the second variant in affected babies. Remember, we're talking about a recessive condition. We expect babies with CF to have two identifiable variants. Now, the results from either the DNA panel or the DNA panel plus sequencing will determine whether an infant is given a positive CF newborn screening result and sent for sweat testing or not. Now, you may recall that individuals with CF have very salty sweat, and so we just measure the amount of chloride in their sweat. That helps us diagnose CF. So sweat testing is kind of the gold standard for how we actually do diagnostic follow-up after newborn screening. In the IRT DNA protocol on the left-hand side, babies with one or two CFTR variants on the panel are sent for sweat testing. Babies who have two panel variants usually have CF, and we typically see a positive sweat test with those. If the sweat test is positive in a baby with only one variant, then usually the CF clinic will order additional DNA testing to try to identify the second variant. If the sweat test is normal in a baby with only one variant, then the infant is considered a CF carrier and usually discharged from follow-up. And the key with this is that typically many carriers are sweat tested to find just a handful of affected infants. Now, on the right-hand side in the IRT DNA sequencing protocol, babies with one variant are called out as carriers, but not sweat tested, and only babies with two variants are actually sent for sweat testing and diagnostic follow-up. Now, at nearly every stage of the CF newborn screening algorithm, there is wide variability in how states choose to perform their testing. And we also know that when babies are missed on newborn screening, so given a negative CF newborn screening result, but then diagnosed with CF, those are called false negatives, about half of those cases are missed at the IRT level because the state has a cutoff that's higher than the baby's IRT was. And about the other half of cases are missed because their CFTR variants are not detected at the DNA stage. Usually they're not on the panel. And so because of this variability, and thanks in part to some very important analysis done by many colleagues, it was determined that CF newborn screening in the US was or is inequitable. The likelihood of detection depended on the state of birth, and so it wasn't uniform across the states. And babies with a false negative newborn screening result were much more likely to be Black, Asian, or Hispanic. I'll just quickly show you what this looks like in the US. You can see that it's really a patchwork quilt of which states are using which variant panels. This is just to demonstrate that variability. So states shown in the kind of lighter tan colors test for anywhere between 23 and 43 different CFTR variants on their panels. States in blue or green have several hundred or 1,000 variants that they're testing. And so this is where we get into why there are differences in detection state to state, because they're using different panels. And now we get into the equity lens. So a major focus of investigating current newborn screening practices has been on whether states' choices at the steps of newborn screening disproportionately affect infants from different ancestral populations. So here you can see the whole CF population born between 2007 and 2020. About 85% identify as non-Hispanic white, 8.6% as Hispanic, and 3.6% as Black or African American. Now, here's the breakdown of babies in this time period who had false negative newborn screening results for CF. This group had a normal newborn screen, but then they were later diagnosed with CF. So even though the non-Hispanic white individuals make up 85% of the CF population, they only account for 70% of the group missed by newborn screening. But when we look at Hispanic individuals, this group accounts for 15% of the babies missed by newborn screening, even though they only make up 8 to 9% of the CF population. Similarly, those who are Black or African make up 6.5% of those missed by newborn screening, but only 3 to 4% of the CF population. Similar story with delay in diagnosis. Almost a quarter of those with a delayed diagnosis are Hispanic, even though the population in CF, the CF population is only 9% or so Hispanic. So essentially what this tells us is that of the babies missed by newborn screening who have a false negative result and consequently a delayed diagnosis, a disproportionate number are of a race or ancestry other than non-Hispanic white. And so in order to address these issues, the CF Foundation convened a committee to address timeliness, sensitivity, and equity in CF newborn screening. And as a group, we decided that all newborn screening programs should aim for 95% sensitivity or true positive detection across the ancestral groups tested by the state. This was partially based on that 95% sensitivity goal of the updated carrier screening recommendations. I'm going to go through each recommendation in detail, but these all address IRT thresholds, variant panels, application of CFTR sequencing, and communication strategies. So here are the 7 consensus recommendations. These are evidence-based, and you'll notice that they all reach, on the right-hand side of the screen, they all reach 100% agreement from the committee. That's a fairly impressive statistic, and so we're going to talk through these. The first 2 recommendations have to do with IRT, that initial first step of CF newborn screening. Recommendation number 1 is that a floating cutoff rather than a fixed cutoff should be used. Floating cutoffs vary by the day or week and involve counting the highest X% of IRT values as elevated. So in some states, it's the top 5%, sometimes it's the top 4%, etc. A fixed cutoff doesn't vary by day. It's just a static number of, say, 60 nanograms per milliliter, and any specimen with an IRT above that is considered elevated. The evidence we reviewed suggested that floating cutoffs are preferred because they account for some of the natural variability that might be present due to seasonality, so IRT values can be affected by temperature, or kit-to-kit variations that affect the test results. But of course, whatever cutoff is chosen is still important. A floating cutoff that's too high will still miss lots of babies. Recommendation 2 states that a very high IRT referral strategy should be used when a state's variant panel does not include all CF-causing variants in CFTR2, or does not achieve 95% sensitivity in all ancestral groups. Now, this is a little complicated. I'll try to make it simple here. A very high IRT referral strategy is a way of catching babies on the newborn screen with rare variants. So even if no CFTR variants are identified on the DNA panel, specimens with a very high IRT level above a very high threshold are considered to have a positive newborn screen or are sent to the sequencing step just to make sure that rare CFTR variants were not missed. We know that infants from minoritized populations tend to have more rare variants, so this strategy is sometimes called a fail-safe to make sure they don't slip through the cracks. Now, unfortunately, there's a very low positive predictive value, meaning that the likelihood of a baby with a very high IRT and no CFTR variants actually having CF is pretty low. IRT can be elevated for lots of reasons, as I mentioned, but some states are choosing to keep this test as part of the algorithm to increase their sensitivity. And this recommendation basically tells states that they should keep this referral strategy if their DNA panels are small enough that they're not reaching 95% sensitivity in their population. Recommendation 3 is that a DNA panel for CF newborn screening should not only include Delta F508, that's the very common CF causing variant, or the original ACMG23. Now, we already talked about the low sensitivity for that test, particularly in Black, Asian, and Hispanic populations. So this recommendation is pretty straightforward. Recommendation 4 is that newborn screening programs should be screening for all CF causing variants in CFTR2 on their DNA panels. This improves sensitivity with particular benefit for minoritized populations. Recommendation 5 has to do with timeliness and states that variant screening should occur at least twice weekly. There are many factors that influence timeliness, including shipping methods, laboratory hours, and frequency of variant testing on blood spots. The evidence showed that doing the testing more frequently was associated with an earlier age of first CF visit and an earlier age of diagnosis. Recommendation 6 is essentially that all states should implement the IRT DNA sequencing protocol that I showed before and perform sequencing as what we call that third tier test after panel testing. This improves the specificity, that is, only picking up actually CF affected babies, and also improves the positive predictive value of the newborn screening test. The key with this is that once sequencing is implemented, only babies with 2 CFTR variants or more should be referred for sweat test. This essentially eliminates the need to sweat test lots of babies who end up being only carriers and then discharged from care. And our final recommendation is that a positive newborn screen result for cystic fibrosis should be sent both to an infant's primary care physician and to the local CF clinic or local CF provider. Notifying both increases the likelihood that the results will be interpreted accurately and that the family will be provided with the right information. So we know that evidence indicates that families really want to have information from a trusted medical provider, like their primary care physician. They want to have a CF specialist notified of the result, and they really want prompt contact from a healthcare provider who's informed and knowledgeable about CF. Now, that's usually not their primary care physician. So they want some information from a trusted provider like their primary care physician. They want other information from somebody who knows CF. That's the CF clinic. So these things can be achieved when both the primary care provider and the local CF provider are made aware of the newborn screening results. I'm not going to walk you through this figure. It's in our newborn screening guideline publication, but this essentially serves as a decision flowchart to help state programs determine how to implement the 7 recommendations. So state programs can start at the top here and say, okay, we've collected our blood spot, we've done our IRT measurement, and then all of those white boxes with the gray diamond will say, okay, well, is your IRT threshold fixed or floating? Then you get to choose from there, and the flowchart tells you how to implement these guidelines. So in summary, CFTR2 has really played an important role in the development of this guideline in providing a list of variants that should be included in newborn screening. This will reduce false negatives in infants who have rare variants not usually included in typical panels. And of course, panels can continue to be revised as more CFTR variants are interpreted, much as we discussed with the same carrier screening guidelines. With implementation of these guidelines, it is expected that CF newborn screening will have improved sensitivity, timeliness, and equity. Now, the guideline publication just came out a few months ago, so I'll have to report back in a year or so as to how implementation has gone. So in putting this all together, CFTR variant interpretation through programs like CFTR2 or other data sets is really key to improving sensitivity and equity in both CF carrier and newborn screening. The CFTR2 project can provide robust, expert, and evidence-based variant interpretations to inform policy decisions. And future data collections will enable the continued refinement and improvement of screening recommendations. I didn't get into this much on my talk, but I'm going to say it now because it's a really important point. The use of sequencing technology is likely necessary to maintain flexibility and adaptability to recommendations. So when we recommend that each state now look at all of the CF-causing variants in CFTR2, that's over 1,000. When we talk about a refined carrier screening list of 100 variants, it's pretty difficult to design a panel that's not sequence-based to include all of those variants. And so increasingly labs are relying on DNA sequencing technology to keep up with these changing lists, essentially. There are too many people to thank who have contributed to or worked on patient registries, CFTR2, the CF Foundation Newborn Screening Committee, and the ACMG Carrier Screening Committee. I hope it's clear that none of this work is possible without collaboration, and I'm very thrilled to have been a part of what I think are really important advances in our interpretation of CFTR variants and their subsequent effects on screening recommendations. Thank you so much for your time and attention today. I'm going to turn it back over to Bob.
Karen Raraigh, thank you for that splendid presentation. That's really terrific. I want to remind our audience that you have a time to now. You can type in questions, comments in the pod that you see in front of you. And once we get those, we'll be triaging all the questions. And of course, this has been such a rich presentation. I want to remind you, you'll have a chance to review it and to share it in about a week or so at captodayonline.com. There's very much to think about here. We'll get into some more of it in our Q&A, but right now, I'd like to introduce to you a special guest, Dr. Annika Alford, works for Devicer. She's the Director of Product Management, and I've asked her to share with you a few slides so you'll for an enhanced understanding of Devicer and what it offers you. Dr. Alford.
Thank you, Bob. Yes, I'm very happy to have the opportunity to present briefly our company today. And Devyser is a Swedish biotech company, and we are operating globally. And for the last 20 years, we have provided solutions for genetic diagnostics and for clinical research. And we are specialized in easy-to-use solutions for complex DNA testing and within a range of diagnostic areas and clinical research fields. And today I would like to specifically mention Devyser CFTR, which is our product for detection of genetic variants in the CFTR gene. And this is a single tube solution which offers flexible NGS analysis which is then possible in any type of lab. And it's very versatile in that it offers testing for neonatal samples, but also adult samples. It has been on the market for almost 10 years, and within Europe, it's cleared for diagnostic usage, and in the rest of the world, including the United States, it's available as research use only product. Yes, and with that, I actually already would like to say thank you to our distinguished speaker, Karen, for that really nice presentation, and hand over back to Bob. Thank you.
Well, thank you very much, Annika. I appreciate that. There's a lot of ability that we have even here in North America to get these tests ordered on an RUO basis and through a reference laboratory. So no one needs to feel left out in this area. Once again, we'll be live now with Annika, Karen, our principal speaker, and myself. And I wanted to begin with a question that just came in from the audience, and I encourage more and more commentary. And I'm going to ask you, Karen, and also Annika to chime in after Karen. We have an interesting question here, as we always do almost with genetic screening questions. What is the evidence based on a genetic abnormality that early detection and intervention improves outcome? Meaning, I suppose, improves outcome for the patient, quality of life, et cetera. Karen, would you like to take a stab at that question for me?
Sure. It actually seems to me like there's kind of two questions there. So
Right.
We know that early detection and early intervention improves outcomes in cystic fibrosis, particularly from a nutritional standpoint. So that was shown many years ago, and particularly in Wisconsin, who started CF newborn screening very early. We can show that the earlier you diagnose those kiddos, bring them into clinic, the better nutritional outcomes that they have. Now, nutritional outcomes are a key component in disease progression in cystic fibrosis. We know that as patients age, if they have poorer nutritional status, they also tend to have lower lung function. So early diagnosis in general is associated with better outcomes. We know that. I think the question is also, how does identifying the genetic abnormality improve that, or how does that tie in with early diagnosis? You know, back in the day when we were doing CF testing with only a few different genetic variants, a lot of that was panel based, and those tests were pretty quick to run, even as part of newborn screening. And they're just a little bit more specific than the biomarkers that we have, like IRT. And so, as I mentioned, there's a lot of reasons that IRT can be elevated in infants. Some of it is due to cystic fibrosis or CF carrier status, and some of it's due to things that are unrelated to CF at all. So by adding that DNA component, we were getting more specific in the infants that were actually being identified by newborn screening, and then we could get them in earlier for diagnostic testing. So hopefully that answers that question.
Thank you very much. Annika, would you like to make a comment to this question?
No, I just wanted to add, also emphasize that since the treatment has improved so much, there is also opportunity with early treatment. So the early detection is really relevant from the perspective of treatment. Yeah.
Yes, thank you very much. Well, very clearly, you've got a lot of interest in this audience. So one of the questions is, when will the list of 100 ACMG variants be available?
That is available. You can
It
go
is available.
It is
Okay.
available. It was published, I want to say in 2023, if I have my numbers right.
Okay.
And the lead author is Josh Degnan.
Josh
If you
Degnan.
PubMed ACMG carrier screening recommendations, you will be able to find that paper, and it's in there. The whole list is in there, as well as supplemental data on how we pulled our lists out of Nomad and things like that. So that is out and available for you to find.
Thank you very much. And you might be interested to know that I've worked with Dr. Degnan several times in these webinars, and he's a terrific source and speaker, as you have also been. It's a great delight to be able to share that. If you have any difficulties with that, just drop us an email, or we'll make sure you get the proper reference. I want to come back to a couple of questions I think that will be very useful to the audience. In your presentation, you shared a map that highlighted the geographical regions included in the latest CFTR2 update. And you mentioned the ongoing global expansion efforts, and it seemed like those expanded efforts were resulting in many, many more variants being discovered and characterized. Could you elaborate just a little more on your strategy to enhance ethnic diversity in the data set? And are you currently pursuing new collaborations with registries to support this goal?
Yes, so I'll tell you, our main challenge, and if you recall from the map, the big holes in CFTR2 are much of the African continent.
Okay.
And a good deal of Asia. Now, we do have some contributions from Japan, from South Korea. We have a small handful from China. Now, we know China is a very populated country, so our small handful is just a tiny fraction of the people there. But part of the issue, actually, is that those are regions of the world where there really is not centralized CF care. There are no national registries in many of those countries. And so that had been our initial strategy, was to go around the world, meet with the national registries, explain our project, and ask them very nicely if they'd be willing to contribute, which many, many have. The issue becomes when there is no national registry. And so we have deliberately tried to partner with especially people who come from different regions of the world and have come to work in the US and then have contacts back in those countries. And so we've made connections with a very nice group in India that recently published a sort of widespread genetic analysis of the Indian CF population. So we have worked with them. They are hopefully going to be getting their contribution approved through the ethics board and then can send their data. And I want to highlight another key collaboration with Professor Milan Macek. He is based in the Czech Republic. He's a clinical geneticist, but he's been running a program to improve access to CFTR genotyping for people in countries that really don't have great access to that. And he's, I believe, global, but he has mostly been focusing on Eastern Europe and parts of Asia and the Middle East. And so through Professor Macek, we've actually had really wonderful collaborations and gotten data from places like Kazakhstan. We have other collaborations from him in the works with places like Uzbekistan and Kyrgyzstan. And so those are our main priorities, is trying to make connections with people who have a clinical contact in those countries, and maybe they only see a handful of patients in their clinic. That's still very valuable data. I will say the other thing is that there is a global registry harmonization group, which is a collaboration amongst people in North America and Europe, to talk about what are the variables that you need to collect when you decide to create a CF registry. So that group has served as a nice resource in countries that would like to start a CF registry and then who might want to also contribute to CFTR2. So we are working on making those connections, facilitating those relationships, and hopefully getting really valuable data, because as you would imagine, those areas of the world have variants that are not necessarily well represented in all of the other populations that we have.
Thank you very much. And if you'd be interested and can send us some information, we'd be happy to put in a little item for you in CAP today. We serve a very large audience.
Sure.
The people in clinical labs, we'd be delighted to help you promote that.
Great.
Let me ask you one more question here that comes to mind. Over time, what is the incidence of CF as it's understood? Is it increasing, decreasing? staying about the same? What explains it all?
It's a great question. Now, overall, I don't know that I can give you an answer. I can tell you that there have been some studies done in very specific populations, particularly those that have really tried to increase their CF carrier screening. So there was a paper, this is probably many years old at this point, out of Israel, where they, as you might imagine, so the Israeli population, you may remember from my slide, the Ashkenazi Jewish population has really a pretty small number of CFTR variants. And so we can pretty easily determine which variants need to be looked at, and you can cover a large percentage of the population. And so they do a lot of CF carrier screening. And they did find that it had an effect on the incidence of the disease. In some ways, the incidence might have dropped slightly, but actually what was more interesting is that the variant profile changed in the country. There was also a paper, again, several years old at this point, out of Australia. As they increased CF carrier screening, they did notice a very slight drop in the incidence of cystic fibrosis. However, we actually heard just recently at some talks in recent weeks that when you look at countries like India, for example, where it's a very large population and they have children at a higher rate than, say, North America and parts of Europe. And so even if CF is not all that common in some of these populations, if the birth rate is high, you still get a lot of children or infants that have the disease. And so I would say overall across the world, it may not be changing all that much, because in some places we're going down a little bit. In other places, if the birth rate is high, we're sort of maintaining that. So I would say overall, I don't have a great answer for you, but we are seeing subtle changes in specific regions.
Very good. Thank you so much. I have another question that I think will interest a lot of people, particularly in labs. And this is the revised newborn screening guidelines that emphasize the use of IRT and genetic testing. One of the questions that always comes to mind in these global issues is, what is your perspective on incorporating the pancreatitis associated protein, or PAP assay, as a second tier screening method?
Yeah, so just for background, for those not familiar, there are many places in Europe that do IRT as sort of their first level. And then they look at another analyte called PAP, or pancreatitis associated protein, as another way of screening for kind of like pancreatic injury. So it tends to look for a similar type of effect as IRT, but it's just a different thing to measure. And in the US, I'm not aware that this is done anywhere, to my knowledge. And, we've looked at a lot of newborn screening algorithms from different states. I think, I could speculate a little bit. There are some places in Europe, and I'll pick on Europe only because I know that PAP is relatively common there. It also may be used elsewhere. There are definitely some places in Europe that are not real interested in genetic screening.
Okay.
So many years ago, people approached the Swedish, Department of Public Health and said, let's put cystic fibrosis on the newborn screen. And Sweden said, you're not permitted to do genetic testing as part of newborn screening. No. And so that sentiment can be felt in many other countries where there's just a little bit of skepticism about genetic determinism. And so if you aren't going to incorporate a DNA component, and many countries in Europe have, but not all of them, if you aren't going to incorporate a DNA component, it's another way to sort of weed out your population and increase the specificity of babies with CF, so that you can do IRT and you can do PAP. And when you combine them, you really narrow down your pool of babies that actually have cystic fibrosis. Now, in the US, generally speaking, we have not seen states shying away so much from genetic testing. If anything, more and more states are incorporating genetic testing and doing more of it to identify babies with CF. And so I would guess that there's probably a little bit of, well, we don't really need another analyte screening if we can just go straight to DNA. So that's a little bit of speculation.
Excellent, but a very interesting answer. We're still a very heterogeneous human population when it comes to our acceptance of genetic testing in some ways, aren't we?
Definitely.
Very good. Well, with that, I'm going to give you the last word. I'll look on my screen. I don't see if someone would like to add something. We've got a minute. But otherwise, I also want to say, as you look at the various states with all these wonderful collaborators as you've listed them in your final slide, many of whom we know, as I mentioned, Josh and Dr. Grody and other very famous folks in the ACMG. Do you feel like we're getting ever better equity working towards that in the States? I mean, is there a positive momentum for that in this particular area?
Yeah, I really think so. You know, I think for a long time, just nobody was really looking at it.
Okay.
And then we had some people that started looking at it, and it became really clear that there was no equity when it comes both to CF carrier screening and newborn screening. And once that came out, there was really a large push from ACMG, from the National Society of Genetic Counselors, from many other organizations to say, you know, this is really unacceptable. And, you know, having now been involved both in the carrier screening committee to revamp those recommendations and in the newborn screening committee, you know, I've looked at the numbers, right? I've seen the raw data of what kind of detection rate we can get when we incorporate more knowledge about CFTR variants. And it is striking. I mean, we've done analysis with the newborn screening results to say, hey, you might only previously have picked up 70% of Asian babies. And now if you do this one thing, you'll get up to 95. That's a huge increase. And I do think, you know, states' biggest challenge with implementing something like this is money, right? Is funding.
Right.
But the CF Foundation has resources to talk about how we can work together. So states, there's now an initiative to sort of share DNA labs. So a state can send their specimens that need sequencing to a lab in New York, say, that does it all the time, then get those specimens back. So I think there's really a push to making this happen, because the states too have seen how valuable it is when you can get everybody diagnosed at a young age, get them started on treatment, as Annika said, and see those improved outcomes. So I really do think we are headed in the right direction. I think a lot of changes have already been made, and I think we're just going to see that continue to snowball.
Very good. Thank you so much. That's a very nice, optimistic close for this wonderful, wonderful program that you provided. And we had one final comment, which complained, of course, about insurance companies. That's no surprise to anybody who's in this audience, but it's a very, I hope you will not forget your mention of lots of help from the foundation, CF Foundation. There are labs that do this routinely, and there are some funds to be able to transfer samples to get proper testing done. So with that, I really want to thank you once again. So let me begin to wrap up. Obviously, we're greatly in the debt in debt to our speaker, Karen Raraigh. We're also in great debt to Dr. Annika Ahlberg of Devicer. We want to thank, of course, Devicer for their support in bringing you this very, very critical program. Again, we'll be posting it in about 10 days. And then finally, I want to thank all of you in the audience. Everybody's busy today in healthcare. Everybody's on their phone and in their labs and working hard away. So when you take the time to join us, we're very grateful for that. And we're delighted that we can offer you such wonderful webinars as the one we've just had today. So again, thanks to Karen, thanks to Annika, thanks to Devicer, thanks to all of you. And with that, I'll bring today's webinar to a close.